Moving on from a rather extensive lecture on genetics, we're going to go to a more practical thing that we see every day, and I'm sure you see every day. Gastroesophageal reflux disease in pediatrics. I just want to spend a few minutes on the terminology because it's often used interchangeably. However, gastroesophageal reflux means gastroesophageal, meaning gastric contents coming back in the esophagus. Reflux means backwards. That's all it means. If you have undesirable consequences from that happening, then it becomes gastroesophageal reflux disease. Every newborn infant is entitled to some degree of reflux. So if you just see reflux, this infant has reflux, doesn't have reflux disease, unless you see the other consequences. And we'll talk a little bit about that. Regurgitation, on the other hand, just means the contents coming up to a variable degree. They can come to the esophagus, they can come to the mouth, they could be spit out. All of that is regurgitation. Rumination is when this content is taken back and swallowed again. And vomiting is when this content comes out of the mouth. So it's really important to use our terminology correctly because it becomes important in clinical management. Another reflux that we often do not talk about is duodenogastric reflux, which is reflux from the small intestine back into the stomach. And we are not going to talk about this today because we're going to focus on gastroesophageal reflux. When does reflux become reflux disease? One, when there is a lot of reflux. So if there is increased frequency of reflux, why does that typically happen? It happens a lot in the newborn infants because the lower esophageal sphincter, or LES, is pretty loose. It's very hypotonic, similar to the rest of the muscles in the baby's body. So therefore you have a higher propensity for having reflux. Also, the other supports that are there to prevent reflux from happening are not as tight. So for example, there's this angle that's called angle of His, which is the angle between the esophagus and the stomach. That's because of the anatomic nature of a newborn infant is not as acute, and therefore it's easy for the newborn baby to reflux. We also have this phenomena called TLER, or transient LES relaxations, which basically means that over time, the lower esophageal sphincter will keep on relaxing several times in a minute in some instances, and will allow some degree of reflux. And that's mostly a release mechanism for the stomach and gastric contents. Any other conditions that increase the gastric pressure or increase the gastric volume will lead to more reflux, and that is again by the same way. For example, kids with cystic fibrosis who are coughing a lot, they will often put increased pressure in the abdominal wall, and therefore they will cause increased gastric pressure. Sometimes reflux could be within physiologic limit and yet be abnormal, and that is dependent on decreased esophageal clearance. So the reflux may be happening within physiologic range, but it tends to stay there, and that's decreased esophageal clearance. Typically we see that in kids with developmental delay, seizure disorders, kids who are lying a lot on the flat on their back, etc. Kids who don't salivate, again, the same population also do not have that frequent swallow as other normal or typically developing kids do. And therefore, they are not able to neutralize any acid coming back from the stomach. Similarly, the same population is again at risk because of poor peristaltic dysfunction. And then there are other reasons where reflux can become a reflux disease or reflux problem, because the refluxate might be very noxious, so there could be very strong acid reflux. By the same token, it could be very strong bile reflux, and we often tend to ignore that. There could be poor mucosal resistance, so if a newborn infant has developed esophagitis, then a physiologic range of reflux will be very noxious for that newborn infant. So let's see a case scenario. A 5-month-old infant who was born at term, seen by one of you guys all the time, coming up, mom is calling you 3 times every week. Spit out started around 1 to 2 months of age. They were initially small, but they have increased gradually in volume. The baby appears happy and healthy and growing up pretty well. He's gone through several formula changes, which is very typical that happens in daily life. And he's being treated with Zantac, which is also fairly common, and ranitidine, you're giving him 3 milligrams per kilo per day. But the reflux is happening. Okay? So in that case scenario, what are we supposed to do? Here's a slide that I want to show you if there's a take-home message in that case scenario is that if we look at a newborn pattern of reflux, it is not present at birth that much. It tends to grow. So in the first 3 months of life, the orange bar is those infants who had reflux at least once a day, and the green is 4 or more reflux episodes in a day. And there are two messages from this graph. That number one, that most refluxes will be less than 4. So most infants will have reflux, which is a small amount or less in number. Also, if you look, that the 4 to 6 month bars are higher than the 0 to 3 month bars. So if you are seeing this infant as 4 months of age, as I showed you in the case scenario, then most likely this person or this infant is going through a physiologic increase in gastroesophageal reflux. The kid is looking healthy and growing otherwise and is asymptomatic, then you just provide reassurance to the family that this infant has normal newborn reflux. Another case scenario, on the other hand, if you see a 16-year-old boy, typically seen in the emergency department, and is presenting with chest pain. You've done EKG, you've seen there's some history of tightness of the chest, you've done physical examination, which is totally benign. The child might have, the adolescent might have some occasional cough, but the chest x-ray came back as normal. You send them to pulmonologist, they did a pulmonary function test, and that was normal as well. So they suspect this is reflux disease because of chest pain. If you look at this graph, which is how the kids present in different age group, the typical presentation of reflux in adolescents mimics that presentation of adults. So this is an analysis of 2,000 adults, and their main symptom for reflux is heartburn or chest pain. Whereas in pediatric population, 3 to 9 years of age shown here in the green bars, they have more commonly other symptoms, but do not have heartburn and do not have epigastric pain as their main symptom. A third case scenario. You're seeing a 2-month-old infant who was born at 36 weeks gestation, came to the emergency department brought by ambulance because the kid was feeding and turned blue. Not an uncommon scenario in any pediatric hospitals. The patient had some history of spitting up with each meal. The spit ups were small, had been sent home on a dose of ranitidine. The pediatric team admits the patient and they call all subspecialties for consults, including gastroenterology. Which brings us to what are the tests we can offer for reflux. And I often hear this question all the time. What is the best test for gastroesophageal reflux disease? And really the answer to that is a question. The question is, what is your question? What are you trying to establish? So each test can answer a question, but is there really a gold standard test for reflux? Also, it's important to know what is the reliability of this test. We can do a bunch of tests, but what is the reliability or reproducibility of this test? And is it going to really help us? If we know the kid is refluxing 5% of the time versus 15% of the time, is it going to change our management? So those are the principles that guide our approach to the testing. So the tests for reflux disease depend on what we are trying to ascertain. So they are guided by presenting signs and symptoms. And here I have listed for you, it's in your handouts too, the basic principles of any testing. And my first test is history and physical examination. And I have to tell you, I have been in 2 major academic institutions, and not uncommonly I'll get a call from the emergency department and they'll say, we have an infant who's 3-month-old presenting with reflux and the upper GI shows, and I say, stop. How often is the reflux? When does the child reflux? What is the infant formula? So history and physical examination comes before any testing. So we do a history physical examination, and I have to tell you, I've done this for 12 or 13 years now, and majority of the time, by the time I've done my history and physical examination, I really know what's going on with this infant. So if you have not done a good history and physical examination, you're actually doing a disservice to the child. So history and physical examination, number 1 test for reflux. Number 2, upper GI series, we'll talk about all these tests, pH monitoring, pH impedance study, endoscopy and other modes of treatment. Upper GI study, Dr. Z is not here, so I can say it confidently, this is not a test for reflux. Please do not take this as a test for reflux. It is done only for one reason, and that is to look for anatomic abnormalities such as pyloric stenosis or malrotation. Often the radiologist will comment, we saw reflux. The problem is that that might be the only time this child ever refluxed. Or if you do not see a reflux in upper GI study, that doesn't mean this child is not going to reflux 10% of the time. So it is a snapshot, it's a picture taken at that moment, therefore it's not a test for reflux. It is a test looking for anatomic abnormalities. pH study, this is an old slide. Why do I know this is an old slide? Because it says pH study. We do no longer do pH studies, we do pH impedance studies. Guidelines for the pH were developed by pediatric surgeons. This person called Dr. DeMeester, he's an adult gastroenterologist in LA County. He used to do Nissen fundoplications, and he would have a bunch of these people who would not respond to the fundoplication. And he said, I need to know more objective criteria before I subject these adults for fundoplication. So the idea for pH probe was to do the probe, get quantitative data on reflux, and then see if that will be useful in making the determination for the surgery. Over time, this was about 20 years back, now 25, the probe has advanced so much because we have single channel, we have dual channel, we have channels in esophagus, we have channels in esophagus and stomach. We can do pH without a wire, and we can do pH and impedance testing. The advantage of pH probe or pH studies, as we traditionally call them, is that it will detect any episode of acid reflux. So it can tell you any symptom association. So for example, that infant who was having apneic episodes, you do a pH probe study, but along with a sleep study, and you find an episode of apnea, and at the same time if acid reflux was happening, you have made a determination that reflux was causing the apnea. However, the limitation of the pH probe was this was only testing acid reflux. So if the reflux was happening but the contents were not acid, the pH probe will miss it. The other disadvantage was that if you're doing this for a teenager and you send him home with a wire coming out of the nose and it's attached to a box, that adolescent is not going to come back to see you again. So people said we have to do something else, and they came up with this wireless capsule pH. So we can do that. We typically in pediatrics we need endoscopy to place these wireless probes, but it basically is a small tiny capsule like that size, which is attached via endoscopy into the distal esophageal mucosa. It's attached about 6 centimeters above the GE junction, and it sends wireless signals to a sensor and records any episode of acid reflux. 4 to 5 days later, this capsule sloughs off and it passes off naturally. So therefore, it's a good test for testing acid reflux. The biggest advantage of this test is that it can stay there for 4 to 5 days, as opposed to a wireless pH study, which we typically do for 1 day. So the biggest advantage is that not only in this study that came out first from Japan has been reproduced in the US in adults, that in the first day you would miss 2/3 of these episodes of reflux in these patients who were not responding initially to anti-acid medication. The other advantage is in having it for 4 days, you can start the study off of any PPI. You start them on a proton pump inhibitor after that, and then you see the response that all these reflux episodes that were happening, the pH dropping below 4, are responding nicely to this medication. So that is the biggest advantage of a wireless study. It still has limitation in pediatrics. It still has a high number of chest pain complaints. Also, these sometimes can get stuck and may not come out, so many surgical removal. The described incidence for that is about 1 in 25,000 probes. And then people said, how about a pH impedance study? So I want to spend 2 minutes on physics here, as Dr. Z did before, and since we are talking about the basics, the impedance is opposite of conductance. It's really easy to remember that if you have air, then you have very poor conductance, therefore your impedance is high. If in that electrode we put water between those two electrodes, the impedance will drop because the conductance is very rapid. So if you put two electrodes and pass electrical current, you can tell the difference between air and water. But if we just put that, we will not be able to tell whether the fluid came from below, as in gastroesophageal reflux, or it came from above, as in a swallow. However, you can tell when the bolus reached that fluid, reached that area, and then when it left. So this is a very innovative test. And because of that problem that I said before, the solution was that we put a bunch of electrodes there. And we can tell if the swallow happened, which is when the sequential drop in pH will happen from more proximal to distal channels, as opposed to reflux, when this will happen from below. And therefore, this study is called MII, or Multichannel Intraluminal Impedance Study. So you can tell if the bolus entry was from top to bottom or from proximal to distal, that will be a swallow, as opposed to a distal to proximal movement of the bolus, then that will be a reflux episode. But these people were really smart when they developed it. They said, we need additional information, so let's put a pH probe there also. So not only can we tell that when the reflux episode was happening, we can now also tell whether this episode was acid or not acid. So there is very little chance of missing any reflux episode with this study. And then they used all the other pH advantages of the pH probe, so that we have dual channel esophageal probes, we have esophageal and gastric channels. But because everything is computerized now, we can also tell how much of this was air, how much of this was bile, if this was food, etc. So the advantage of this test is that we see this reflux episode where you can see this is the channels, and the bottom channel is the pH, and the pH dropped, and that's a typical acid reflux, as opposed to when this reflux episode happened, the pH remained above 4, and therefore it was a non-acid reflux. So therefore, if you see an episode like that with apnea and there was no drop in pH, then you know that you are seeing apnea associated with non-acid reflux. And these are the normal values that are taken from adult data for both patients who have the study done on PPI versus not on PPI. The last test that we often use is an upper GI endoscopy. The advantage of this test is that it looks for underlying causes. This is the bottom line, we do the endoscopy. Not only that we are gastroenterologists, we like this procedure, but also because this gives us the underlying reasons for reflux: food allergy, H. pylori infection, etc. We also can see for consequences of reflux, such as esophagitis. So you can see in a normal person there is no irritation here, whereas if you have esophagitis, you will see more irritation and consequences of reflux. We also can determine if there is findings such as stricture or Barrett's esophagus. So now you've made the diagnosis of reflux, how are you going to treat it? You're talking only about reflux disease today, so what are the treatment options for infants? Most commonly, in newborn or developing infant in the first year or so, you could use lifestyle changes, such as changing the formula composition, you could change the volume, but most of that has already been tried. We'll talk a little bit about sleep positioning, and then we'll talk about the medications and surgical therapy. Thickening the feeds is a double-edged sword as a reflux treatment, because this is an example of an unthickened formula that flows down. However, the recommended dose for thickening of the formula is adding 1 tablespoon of rice cereal to each ounce of the formula. So really the way you know that you have thickened the formula is if it looks like this, which is pudding, and you have to cut the nipple for the things to go. So if your parents are not doing that, then they are not thickening it adequately. The reason it is a double-edged sword is because thickened formula will reflux less, however, it will delay the gastric emptying, so you may still continue to see reflux episodes. The reason this is advantageous in certain individuals, infants, is especially those kids who are failure to thrive, because by adding the rice cereal, you're adding the extra calories that they need. They're also not losing that formula that they were actually losing by spit-ups. So you decrease the episodes of reflux, but you also are able to add calories. This was the landmark study done by Susan Orenstein, which showed that in the orange bar you have the unthickened formula, compare that with the green, which is thickened formula, where you are increasing the caloric density and you're decreasing the time of vomiting, increasing the sleep time, and decreasing the crying time. Prone positioning and gastroesophageal reflux. If you look at the AAP recommendations, every child should be supine, and that is true. However, it does mention special conditions, and gastroesophageal reflux disease is one of those conditions where the infant has a higher propensity of reflux if the infant is in the supine position. So left lateral position might be a good appropriate compromise for such a patient. Coming on to pharmacotherapy, the medications often used are antacids, H2 blockers or H2 receptor antagonists, proton pump inhibitors, prokinetics, and surface agents. This is a typical parietal cell. These are all the receptors that stimulate the proton pump. The reason proton pump is called proton pump because it exchanges a single proton, which is hydrogen, in exchange for the potassium. So that produces the hydrogen in the gastric lumen that combines with the chloride and form hydrochloric acid, the strongest acid, and brings the pH down to 1 or below. So H2 blockers only block one of the receptor, which is histamine. The rest of the receptors are still active, and therefore it is partially suppressing the acid production. And these are the doses for H2 blockers. These are on your handouts. Proton pump inhibition, on the other hand, is where these pumps are really inactivated. These medications should really be called proton pump killers because they actually inactivate for the life of the pump, and therefore these medications are effective for 20 hours, which is the average half-life of a proton pump. In 20 hours you'll replace half of your proton pumps, and therefore you do not really need to give them twice a day dosage of that. These are the doses for the proton pump inhibitors, and esomeprazole or Nexium is the strongest. It's typically recommended for somebody who has ulcer. Lansoprazole or Prevacid, I like it because it comes in a formulation called Solutab, which is very easy to administer, especially those who cannot take pills. Omeprazole is the old purple pill. It only comes as a pill. And pantoprazole is IV medication, and rabeprazole is the longest half-life, so I use it a lot in patients who have nocturnal reflux. That brings us to the Achilles heel of gastroesophageal reflux disease, which is prokinetics. We really do not have very good prokinetics. We are experimenting with all other medications. We are using side effects of other medications as the major effect. For example, erythromycin, most commonly used prokinetic these days. We use a very tiny dose, 10% of the typical antibiotic dose, as a prokinetic medication. Domperidone is not available in the US, however you can get it on the internet. Metoclopramide is very readily available, has been used for years, however has serious side effect profile. That is the end of pharmacotherapy, and that brings us to which patients are appropriate for reflux surgery. The problem with reflux surgery is that it is not that it is very successful. The success rate is over 80 to 90% in most series. However, the problem is it still has very high mortality rate, which is about 5%. And overall complication rate, 1 in 5, including the need to reoperate in about 20% population. So it has to be done in very select population. So the key points that I want you to take home today is that the testing for reflux should really be directed towards the management of your question. Whatever your question is, that should guide what test should be used for the reflux assessment. Upper GI is not a study for reflux. Upper GI is a study for anatomy. Impedance pH testing is useful to identify patients who do not have acid reflux only, but may have acid or non-acid reflux combined. And combined pH and impedance testing is especially useful for children who have reflux and other symptoms such as pulmonary complications. Anti-reflux surgery should really be reserved for refractory cases who do not respond to pharmacotherapy. Thank you.